Hello, friends. I'm Dr. Bhupendra Prasad Sharma, a senior consultant surgeon and in charge of the burn unit at Nemcare Hospital, Guwahati, in the Indian state of Assam. In my burn care channel, I've already uploaded a number of videos, which has given some thoughts on different aspects of management of burns. Today, I'm going to talk about the fluid resuscitation and nutrition management of burns. Let me share the slides. Dear friends, fluid resuscitation and nutrition in burns is a very important subject in the management of burn patients. A formal fluid resuscitation is required in burn patients if, in case of children, there is more than 10% of total body surface area burn, and in case of adults, more than 20% total body surface area burn. The rate of infusion, of course, will depend on the size of the burn itself, the time since injury, and also the presence or absence of associated injuries. I must tell you that earlier the fluid resuscitation is given, the better is the prognosis in burn patients. Now, there are a number of formulae for calculation of fluid requirement of burn patients. These formulae are only guide, and you should also use your clinical equipment to really decide the amount of fluid to be infused. The number formula is Evans formula, where in the first 24 hours, we will give about colloid 1 milliliter per kg per percentage of burn, normal saline 1 milliliter per kg per percentage of burn, and we also add 5% dextrose, about 2000 cc in an adult. The second is the Brock formula, where in first 24 hours, we had about colloid 0.5 milliliter per kg per percentage of burn, and a ring-directed solution of 1.5 milliliter per kg per percentage of burn. And also 5% dextrose is to be added, about 2000 cc in case of adult. In the second 24 hours, colloid and crystalloids requirement is half the amount that is given in the first 24 hours. The third formula, which is probably the most preferred formula and used extensively by most of the burn surgeons all over the world, is Parkland formula. In Parkland formula, in the first 24 hours, we give only ringer-lactate solution. The formula is 4 ml into body weight in the percentage of burn. The calculated amount is given like this. Half of the amount is given in the first 8 hours after burn. 1/4 of the amount is given for next 8 hours, and the rest 1/4 in the last 8 hours of burns. If the patient happened to come to the hospital later on, suppose about 8 hours after burn injuries, then you have to calculate the amount for 24 hours and give the whole amount in the next 16 hours itself. That means you have to increase the rate of flow of fluid so that you can cover the whole amount in less amount of time. Electric burns, of course, require more fluids than the calculated amount. That is also to be remembered. Now, in next 24 to 48 hours, fluid requirement should be titrated against the hourly urine output. That means you have to calculate the urinary output per hour, and then you regulate the fluid requirement accordingly. 5% dextrose and colloids like plasma and plasma expanders may be added in such cases. After 48 hours, one may consider blood transfusion if is needed. But blood transfusion is never given in the first 48 hours because there's always hemoconcentration in burn injured patients. 20% human albumin may be given if albumin level is low. Now, another important thing in fluid resuscitation is the monitoring of fluid resuscitation. The clinical monitoring as also as invasive monitoring. We can give a lot of importance to clinical monitoring, like your pulse and blood pressure monitoring, where if you get tachycardia and hypertension, probably fluid resuscitation is not enough. You have to increase the fluid. Then, of course, the urinary output. You have to maintain an hourly intake output chart And urine output should be maintained on an average about 1 cc per kg body weight per hour. If the output increases, then of course you have to reduce the fluid infusion in the next hour. And if the output decreases, then you have to increase the fluid infusion in the next hour. That means according to urine output, you have to adjust your fluid requirement or fluid infusion. But in children, urine output should be taken as 1.5 cc per kg per hour, not 1 cc. If you find that it's cold climate extremities, it indicates hypovolemia. In that case, you have to increase the fluid amount. If there is sensorium, which is decreased, then of course, it also indicates hypovolemia, and you have to increase the fluid infusion. Now, there are also some invasive monitoring, out of which central venous pressure monitoring, which can be easily done in many of the many Barnes units, and it gives a very good guide to fluid replacement. But the pulmonary artery pressure, pulmonary capillary wedge pressure, estimation of blood volume and cardiac output, these are also good monitoring, but then these are not available in all Barnes units. If available, definitely it can be. But you must remember one thing, that the different resuscitation formulae are only guides to fluid calculation. They did not be strictly adhered to. The clinical judgment and monitoring should be the final deciding factor in fluid therapy. This has to be remembered very clearly. Now let me give an example of fluid resuscitation. This is a patient about 60% body surface area burn, upper part of the body, mostly full thickness burn, which we calculated by drawing a diagram like this, and then finding out in different areas from back and other things, and it ultimately came out to about 61%. Now it is taken as 60%. Now the patient's body weight is also 60 kg, percentage of burn is 60%. Now, fluid requirement according to Parkland formula in the first 24 hours is 4 ml into 60 into 60 is equal to 14,400 milliliter of Ringer lactate solution. Out of this, we give about 7,200 milliliter to be infused in the first 8 hours, 3,006 milliliter to be infused in the next 8 hours, and 3,600 ml to be infused in the last 8 hours. And this is the way we infuse fluid. After 24 hours, of course, we have to infuse the fluid according to urine output. And of course, we can add dextrose solution for caloric requirement. Now, coming to the nutrition in burns, I think it is very important to give a good, adequate nutrition to the burn patients to have a positive effect on management. As you know, severe burn leads to prolonged hypermetabolism, and there is also protein catabolism and erosion of lean body mass. Hence, there is, to provide adequate nutrition, it causes protein breakdown with impairment of wound healing, diminution of immunological competence, and lowered resistance to infection. So these are all problems that is created if proper nutrition is not given. Hence, the goal of nutritional management is to promote wound healing, to minimize risk of infection of the burn wound, and to minimize metabolic disturbances during the course of treatment. The idea is to prevent weight loss of the patients at any cost during the course of management. The aim of nutritional managements are to provide nutrition through enteral route as early as possible, maybe 6 to 18 hours post-burn, to maintain 5 to 10% of pre-burn body weight, and to prevent micronutrient deficiency. To maintain that a high protein and a high calorie diet with supplementation of vitamins and micronutrients are very, very essential. Now let us know what are the advantages of oral route nutrition in burn patients. If you give oral nutrition to the burn patients as early as possible, it will prevent the translocation of normal intestinal flora, which are required for digestion. Just consider, if you do not give anything orally, these bacteria, which are normally engaged in digestion, they will be translocated to other places and they will cause infection. To prevent that, we should give oral feeding to burn patient as early as possible. Oral feeding also improves nitrogen balance. It reduces the metabolic response, that is the hypermetabolic response, and also reduces immunological complications and consequent mortality. That's why, as soon as possible, as soon as the patient can tolerate oral feeding, one should start normal diet with supplementation of eggs, sugar, butter, and curd. This will give a very good nutrition to the patients. We have got a very good indigenous method of giving high calorie, high protein diet, which we used in our unit also, where we use about 1 kg of curd, 4 numbers of banana, 4 numbers of eggs, and 8 teaspoonfuls of sugar, which are all mixed in a mixer grinder, and a solution is given by mouth or by ice tube. 30 cc given per hour. That means you have to give frequently in a small amount because it is very sweet and many patients do not tolerate orally. In that case, you have to give by ice tube. It gives a 1 milliliter of this solution gives about 1 calorie. So you can imagine this is very good calorie diet. Now there is some adjunct to other nutrition. It is said that the glutamine preparation not only gives nutrition to the patient, but also enhances the immunity. This new nutritional therapeutic modality has been used in severely burned patients for regulating cell function, improving metabolic states, and also enhancing immune functions. We give this very regularly to our burned patients. The other adjunctive therapy are said to be used by many burn surgeons. Oxandrolone. It is an orally administered synthetic anabolic steroid used as an effective adjunctive therapy to provide weight gain and also to reduce muscle mass catabolism. 10 milligram tablet twice daily in the acute phases of burns has shown to increase the lean body mass levels. The other adjunctive therapy may be given by human growth factor. It is also being used in the doses of 0.2 milligram per kg per day in adult burn patients. It decreases the muscle wasting and improves net protein synthesis. Now, propranolol is another drug which is given in a dose of 200 milligram per day. It also seems to improve the protein synthesis. There are some surgeons who prefer a combination of all these, like growth hormone plus propranolol or oxandrolone plus propranolol, and they say that they get a better results. So it is up to a person to choose which one they want to give. Now, what I want to say the last, that the burn patients are in severe malnourished state. So nutrition plays a very important role in burn patients, and hence you should give a lot of importance to nutrition management of the burn patients. With this, I thank you very much for your patient listening, and I hope I have been able to give some thoughts on this nutritional and fluid therapy in burns. If you like this presentation, please subscribe to my channel, Burn Care with Dr. Bhupendra Prasad Sharma. Thank you. Thank you very much.